Good morning, everybody. Thank you very much, Dr. Pawan Chalise and the Nepal Association of Urological Surgeons to have given me this opportunity to speak about the diagnosis of interstitial cystitis or bladder pain syndrome. I bring with me greetings from the capital of country, New Delhi, and this is the hospital where I work, Apollo Hospital, New Delhi. That yes, there are so many terminologies. There is interstitial cystitis, bladder pain syndrome. We are sticking on to the bladder pain syndrome and the interstitial cystitis because as of now, it is difficult to clinically differentiate between these two. Before we say how to diagnose bladder pain syndrome or interstitial cystitis, we should know what we are looking for. So this is what we are looking for. Pain or discomfort in lower abdomen and or urogenital area of more than 3 months duration, which is worst on full bladder, along with one or more urinary tract irritative symptoms like frequency, urgency, and nocturia, with or without standard stigmata on cystoscopy, provided another discernible pathology which is likely to cause these symptoms has been excluded. So the pain can come from any of these dermatomes coming from or the nerve supplies from the suprapubic to inner thigh to the posterior thigh, and of course this is the area, but many people would also call it pain around anus or burning sensation around anus, which is again typically we have seen which is associated with bladder pain syndrome. Then we should ask, are there any aggravating or relieving factors? When is the pain maximum in relation to micturition cycle? Is there any relationship with menstrual cycle? Is there dyspareunia, whether it is superficial or deep? Is there a relationship with ejaculation or a relationship with posture? So most of the time patients come to us and they say there is a burning sensation. So if it is in the lower abdomen, perineum, vulva, and rectum, then of course we are looking at something which is closer to bladder pain syndrome. Is it occurring all the time or is it related to the micturition cycle? Unless it is related to the micturition cycle, I would not be keen to call this as coming from the urinary tract. But there are exceptions, of course. So pain is worse just before passing urine. Pain is worse. That means it is originating from the bladder, and perhaps it is related to the filling of bladder. And as soon as the bladder is being empty, the patient feels some relief in pain. If there is no pain till the patient starts passing urine, then it is perhaps urethritis. And then if there is pain which starts towards the end of urination and persists for some time, then in a woman, we would think perhaps there is excoriation around the urethral meatus in the vaginal wall. It could be simply senile vaginitis or senile urethritis. But of course, one should not forget a stone stuck in terminal ureter or uretrovesical junction or submucosal ureter can also give rise to pain, which tends to persist for some time after passage of urine. But of course, that's not going to stay for 3 months by and large. Coming to dyspareunia, it could be superficial or deep. Superficial dyspareunia is usually due to a mucosal lesion around the vaginal introitus, and the deep one is related to inflammation either in the bladder, posterior wall of the bladder, or the uterus or internal genitalia of the female. So when we come to the differential diagnosis, the closest is of course overactive bladder. But if you see that overactive bladder very rarely has bladder pain. Both have urgency, frequency, nocturia, and of course there could be a fear of incontinence. So if I have to differentiate, ask this question to the patient. If you have a desire to pass urine and there is no facility available, will you have pain or will you be scared of a leak? If the patient says that she has a scare of leak, then perhaps we are dealing with something like overactive bladder. And if it is pain that is causing that she's scared of, then of course we are looking at a bladder pain syndrome. And another leading question is that when you wake up from sleep to pass urine, is it the full bladder sensation or is it the pain that wakes you up? So if the patient says, no, I don't have pain, I just wake up because my bladder is full and is troubling me. So that's good enough. I go and pass urine, but there's certainly no pain. So obviously, this is an overactive bladder. And if the patient wakes up with pain, then perhaps it's bladder pain syndrome. And many of these patients will tell you that they're scared to go off to sleep because if they go off to sleep, if they fall asleep, their bladder feels beyond a particular sensation and they wake up with excruciating pain in the pelvis and they have to rush to the washroom to pass urine. And of course, we have a horde of the confusable disorders which we need to exclude on the basis of history. And of course, an examination, if there are scars of the previous surgery, if the scars are bad on the skin and the parietes, of course, there could be scars intrapelvic. That means there could be a scarring of the bladder along with other organs, and that can mimic something like a pain which varies with micturition cycle. And one should be careful for such patients. And of course, local examination becomes imperative, like we go for an examination as an MD gynae or a student is taught, we must see, we must feel, we must examine all the steps of the pelvic examination as in female and in male. Any areas of perineal tenderness have to be seen. We have to make a note of the tone of the pelvic floor. If there are any trigger points, we need to assess that, and any myofascial bands must be looked for because they are once you have seen one myofascial band, you can never miss it, but you must see first one before you can be confident of picking them up. A focused neurological examination must be done in case you feel that there's a need or there's a history which points towards that. Coming to a word about pelvic floor spasm, it could be secondary or it could be primary. It can be secondary to the pain itself, or it is the primary cause of pain, then sometimes it may be difficult to differentiate between the two. But of course, if there is a history that the pain increases with change in posture, then perhaps it is primarily coming from the lower back pathology causing spasm in the perineal muscles. Differentiating from chronic prostatitis could be difficult, but I can tell you that if the pain starts at the beginning of the urination and stays for some time, it is likely to be chronic prostatitis. And on examination, suprapubic tenderness is more commonly seen in a bladder pain syndrome, and a DRE may show a tender prostate in a male in such a patient. And if there is still some doubt, we can instill intravesical lignocaine. If it takes away pain instantly, then perhaps the pain is coming from the bladder. The test that I would recommend is, of course, there is no doubt that we have to have a clinical history, physical examination, frequency volume chart, ultrasonography, and urine analysis. These are must. If there are leukocyte esterase, nitrates, and pus cells in the urine, we are looking at an infective cystitis, even if the urine culture is sterile, because presence of any of these means there is infection. Ultrasonography, because we remain in an area which has endemic stone disease, and of course we have a high incidence of tuberculosis. So ultrasonography should be mandatory in our subgroup of patients. Cystoscopy, again, we must have an opportunity to look and exclude serious diseases, and bladder biopsy has to be taken. Unless the if there are any of the signs of infection on routine analysis, culture can be done. Or if there is a reason, we can do a cytology. Symptom scorings and quality of life scoring should be done, especially if you are doing an academic exercise. Urodynamics is rarely indicated in bladder pain syndrome. So cystoscopy is not essential for diagnosis of ICBPS. In clinically diagnosed case, it may be just normal, and it should not be preferably performed under local anesthesia. It is painful to give more pain to the patient who is already suffering from bladder pain. And one need to look into a patient is because sometimes the bladder may seem normal to begin with, but if you look for a longer period, you may find some stigmata there. And it gives an opportunity to do hydrodistension under anesthesia. And if you find Hunner's lesion, you can ablate them. This is a typical Hunner's lesion that I brought. So it is a pale interior with radiating capillaries. parallel capillaries radiating, and rest of the bladder, if you notice, appear to be reasonably normal. So there is a localized area, and this is an early Hunner's lesion that you can see. And when you distend them, they can just crack and cause raining of blood. So this is what is called raining of blood. And here is a small video, if the time permits, that there are multiple Hunner's lesions. And these lesions, you can see rest of the bladder is normal, and they appear to be, sometimes they can be connected with fine strands, sometimes they can be kissing lesions one over the other, and you can see that on distension they become more pale and they just crack down. The Hunner's lesion is getting cracked, and when you decompress the bladder, there is raining of blood. Note that the bleeding occurs only from this area. Rest of the bladder is not bleeding. So this is very important when you're doing a cystoscopy. There's a localized area which is bleeding. There are two Hunner's lesions here. They were kissing lesions in this case. It is largely a clinical diagnosis. Spend time while talking to the patient, and that is the key. And usually it is the patient who spells the diagnosis. Thank you very much for your kind attention. If there are any questions, I'll be very happy to answer. Thank you.